We will first start with flexible esophagoscopy by Dr. Ashok Purohit, sir. Thank you, sir.
Good morning, everybody. So, this is something called as transnasal esophagoscopy, which we are talking about. And first of all, I would like to wish you good morning. So then, this transnasal esophagoscopy is a new concept which has come into ear, nose, throat field last 10 years. And which is a fantastic concept which has been came very recently, because I'll tell you, if you are aware of that, most of the I suppose you are students or consultants, I don't know, there are some hidden areas in ENT where you miss out the diagnosis. My always teaching to my students is that you should not miss any diagnosis. Some patient comes to you with any complaint, even if it's a earache, which is a simple to look at. But if you don't find anything and the person keeps on repeating the same complaints again and again, you should be thoroughly investigated. There are so many hidden areas of malignancy or diseases in ENT that unless you have this equipment, you cannot reach there. So anyone who comes with just a simple earache, you cannot say that, okay, it's just a psychological, you do the test, you say it's a neurological. It's not so. Many times you find some malignancy, some disease, somewhere below your routine examination setup. What we do is the patient comes to you in the OPD, you see, you put a headlamp, you see it, say, at the most you put a indirect laryngoscopy mirror and try to see some few things, but you don't miss out. The most dangerous area, which I myself has come across for the last 35 years, is the post-cricoid area, which is thoroughly missed out. I remember patients who have come with the complaints. One patient, I'll tell you, had just came with a young lady of 32 years, came to us with some pain in the throat and the earache. What we said, there was nothing there, but she had a thyroglossal cyst. So her every focus was on that thyroglossal cyst. We did her sonography, nothing was found except the thyroglossal cyst. Then I suggested we should be doing a transnasal esophagoscopy. So what are the advantages of transnasal esophagoscopy? One thing, it is far superior as far as ENT is concerned than the gastroscopy. What gastroscopy people do, many people, what they do is they just refer this patient to the gastroenterologist. They say there is nothing in the nose, throat, you go send the patient to the gastroenterologist to do the scopy. And the gastroenterology, if you see how they do the scopy, of course, their concern is more of esophagus and the stomach and down below. So what they do is they make the patient lie down, they just pass or keep the mouth gag, they just pass the big scope inside, and it's so big, the patient gets scared first, starts vomiting, and with the vomiting, the esophageal opening opens up and the scope passes away. They don't look into the oropharynx, hypopharynx and larynx. It's just a pass-by, they just, the way we say we travel somewhere and this city has just bypassed us. I bypassed that city. It's same as that. So the sending patient for a throat pain to the gastroenterologist is absolutely a wrong thing. They are not meant for that. Now what TNE does, it's a transnasal esophagoscopy. Two things. One is done in a sitting position. So patient is in an upright position with everything fine. Second thing is, you have the bird's eye view. When the scope is passed, it goes from the nose, it passes along the floor of the nose. So you need to examine the nose. You first, how it's done under local anesthesia, you give the patient a confidence, you explain them the procedure, how you can do it. Even we have done small children with this, because the scope size is 1.5 mm. And it has a working channel from where you can do the biopsies. It has a working channel from from where you can do pass the guide wires, from where you can pass the different forceps, try to take the biopsies, you can try to remove the foreign bodies. In fact, I did not know, because I have a lecture on this on TNE, that's why I not presented this here, but I am explaining you. So what is done is, you explain the procedure to the patient, let the patient be comfortable, you put nasal nose, nasopharynx, so your nose is examined, your nasopharynx is examined. Now you are going down below where you have the your oropharynx, you could go down to the oropharynx. Now you have a bird's eye view, which is a direct view of your hypopharynx and larynx, which is the most important. So always I tell to new people who are trying to invest, or who are interested in this, that if you want to invest a scope, you always go for a transnasal esophagoscopy. It has the tremendous advantage over all scopes. So your nose is examined, your larynx is examined, your hypopharynx is examined, the base tongue, which is another area, which is examined. You tell the patient to say E, so your epiglottis falls down, you have a beautiful view of base tongue. So base tongue malignancies, base tongue diseases, base tongue foreign bodies can be easily ruled out. I have seen many patients who have come that I had a fishbone which has been ingested, and now it has that, I have seen couple of doctors, but there was nothing inside. Then the X-ray neck was done, but it's a so tiny thing, it's not been. I have seen the body shape, the small things which are impacted there and troubling the patient, because they are small but they irritate. So that fits into it. So when you have a view from top, you have this epiglottis which is going posteriorly, and you have, epiglottis going posteriorly, and you have the base tongue which is visualized. So you can see the base tongue tumors, you can see the base tongue foreign bodies, you can see the hypertrophied lingual tonsils, you can see keratosis there, you can see fungal balls there, many things which I have missed in the OPD. So then you would little turn to the one side, you have the beautiful view of your piriform fossas. You have the piriform fossas which has been inspected. And piriform fossas, another place which is a hidden malignancy, which is the hidden place where you get some diseases, and they just present with the earache. Because piriform fossas is lateral to the larynx, they are lateral to the airway or the food passage. So these patients don't complain of change of voice, they don't complain of dysphasias, but they complain of earache, and many earaches are missed out. So you turn it to the right, you see the right piriform fossa, left piriform fossa, you turn to the right, you see the right piriform fossa. Nicely examine it. You can see the beautiful blood vessels, even the superior laryngeal nerve passes from there. You can see that. Now then you inspect the larynx. You have the beautiful view of larynx. It is as, I won't say that as good as your laryngoscope, but it's a chip-on-tip camera. It has a chip-on-tip camera, so it has a beautiful view of your larynx. And where you see the vocal cord mobilities, you can see the false cords, you see the ventricles, you see the anterior commissure. The anterior commissure is another area which is always missed out. When you do an indirect laryngoscopy, the anterior commissure is always missed out. So you have the bird's end-on view of your anterior commissure. You see the patient is very comfortable. Tell patient to say E, see the movements. Here you can't, of course, appreciate the vocal fold mobilities, not mobility, I'm saying vocal cord vibrations, because it's not a stroboscope. So you see that, even the subglottis is seen well, posterior pharyngeal wall is seen well. So once that has been done, once you have confirmed all these things, then the most important area which I personally feel is a postcricoid area, which is always the area which is missed out. So then you take the scope to one side, towards the piriform fossa, go back and tell patient to make the swallowing movements. When the patient tries to do the swallowing movements, your postcricoid gets opened up. And when it opens up, within that time, you have to just pass the scope. You examine it and then pass the scope. That is the difference with the gastroscope and the TNE. Gastroscope, they don't have time to look into the postcricoid, and its size is big. So patient is uncomfortable, is gagging, is vomiting here, patient is nicely sitting. Even we have done the children sitting on the parents' lap, and we are doing it beautifully. They are just sitting quietly. So you examine the postcricoid. Many times you see some irregularities, you see the webs, you see the Plummer-Wilson syndrome there, you see few things out there, and once that has been done, you go down. Now again thing starts because it has a working channel along with insufflator. That is the difference between the bronchoscope and this. The bronchoscope size is the same, but it doesn't have the insufflator. It has an air insufflator. Esophagus is a collapsed organ. So when your scope is going through the esophagus, you have to continuously keep on pushing the air. So esophagus keeps on opening up. And when you open it up, you start seeing the mucosa, you start seeing the esophageal pathologies, you start going down, you go up to the lower end where you see that gastroesophageal margin junction where we call it cardia. Go down, go into the stomach. I won't say that you examine the stomach, you are not the gastroenterologist, but generally you look at for sometimes you see some pathologies there. I remember one patient coming to me with something, and why I don't know, I said, we'll do the scopy for you. He was a healthy fellow, and we found the malignancy at the stomach. Of course, then I referred this patient to the gastroenterologist because that is not our domain, but we shouldn't be missing it out. Second thing, another biggest advantage where I get the references from the gastroenterologist to the ENT surgeon is the patient of a trismus. And we know our mawa gutka is our national food, and people at our area, they are thoroughly eating mawa gutka. So even in fact nowadays I stopped telling them don't eat. I say you eat. Because we have a super specialist. Gastroenterologist referring patient to us for a scopy is a super specialty. Super specialty. Dr. Kashid sir will agree. So once they don't able to do the gastroscopy, we do it and we give the report. Third thing, nowadays this TNE has another advantages, therapeutic advantages. What are the advantages? One is foreign bodies. We remove the foreign bodies. We have the forceps where you can catch the foreign body, we take it out. Small pieces, small things you can. Biopsies, of course, I told you. Any biopsy from the larynx, from the nasopharynx, from the piriform fossas, from the base tongue, from the postcricoid, from the esophagus, up to the lower end of stomach. You can take the biopsies very easily. Third thing, we have those big prongs from where you can grasp even the small pieces of betel nut, which we can take it out. Now, another important thing is we can do intubations with this. Both intubations is laryngeal intubation and the passing a Riles tube. Laryngeal intubations, I'll tell you what we do. We get the patient referred to us, or they call us that you come down and do the patient as a trismus. I want to do a release for thing or something procedure where we want to intubate the patient. The general surgeons, orthopedic surgeons, they call, even the facial-maxillary surgeons, they call us. I don't go there. I tell, send the patient to me, I'll intubate and send you back. What we do is, we put the nasal tube, give the block. At our setup, we pass the TNE scope. Once examine that, once it has been done, we pass the scope through the endotracheal tube. We intubate it and pass it through the nose. So nasopharyngeal intubation has been done. Patient is comfortable. He walks down from the OPD, goes to the respected hospital, gets operated. So we don't go. Let them come to us. Third thing. Nowadays, this must be the, Siddharth is here, he will tell, this was the third patient came to us in this last week where they have done thorough mandibular resection with free flaps and everything, where patient wanted to put the Riles tube inside and they were not able to do at any cost. So the patient was referred from the onco surgeon to us to pass the Riles tube. What we did, we passed the nasopharyngoscope, transnasal esophagoscope, we went inside, we passed the guide wire, we took out the scope, we took the Riles tube, cut the end of it because it's blunt. It is loaded on the guide wire, and gradually we passed inside, and the scope, the tube was in the stomach. So now it has become so common for us that patient from the cancer surgeon with the very much bad dissections, they come to us, we intubate them, send them, and I charge around 10,000 for this. So I'm just telling you. So this is a simple procedure, takes 2 minutes for us. So this is the transnasal esophagoscope. It's an incomplete ENT scope. So when you are want to invest, I would say go for a transnasal. Another thing, sir will cover in the bronchoscopy, so I'm not going into it. But these are same size of bronchoscope. Only it has an advantage. It has a insufflation. So we same scope we use as a bronchoscope, and whatever sir will tell for a bronchoscopy, we do with this scope. So for newcomer who wants to buy something new, go for a transnasal esophagoscopy. So it is a wonderful complete ENT scope. Thank you. Many things we do with, still we do with this. माझं लेक्चर आहे म्हणून मी आणलं नाही, खाली एक लेक्चर आहे माझं ट्रान्सइजो, ते मी जाणार आहे. तुम्हाला पाहिजे तर मी घेऊन येतो 2 मिनिटात. ह्यांचं झाल्यावरती मी दाखवतो काय करता येतं.